ونبدأ أول محاضرة مع الدكتور ديرار الشهاب اختصاصي جراحة الصدر ليتكلم عن سرطان الرئة أحد أهم وأخطر عواقب التدخين في الوقت الحالي. فليتفضل.
All right. Assalamu alaikum. I would like first of all to thank you all for being here, and thank you for inviting me to present the lecture about lung cancer. It's the heart of my job, actually, heart of my career. And I choose that the question is, can we hold the lung cancer horses? Can we kill the beast of lung cancer or not? I think it's going to go with the theme of this conference. So, sorry, please. Just a second. Oh, okay. Thank you. So, lung cancer has been and is a significant problem across the world and all around the world. Worldwide, it is the most common cancer around the world, and it has the highest mortality and morbidity of any cancer like around the world too. For example, every single year, it's about 1.6 million new cases around the world that constitute about 12% of all new cancers, and 1.4 million deaths, that is about 18% of all cancers. Lung cancer is the most common cause of death, as we see here, among men, and that was since 1953, but recently, fortunately, is now decreasing. However, death rate has increased among women since 1985, and finally it has been plateauing and has plateaued. Unfortunately, half of cancer death among women is due to lung cancer. However, in Kuwait, it's not that common. I'm not sure why, but the cancer registry in KCC between 2000 and 2008, there were 704 cases registered here in Kuwait. That accounts probably 5.4% of all cancer cases. It is ranked in Kuwait for Kuwaiti males number 4, and Kuwaiti females is ranked number 9. That's 9. And the non-Kuwaitis female is number 12. In comparison to the rest of the world, lung cancer in Kuwait lies probably at the lower end. Do we have laser? Right. Lung cancer in Kuwait is basically at the tail of this graph. However, in comparison to lung cancer in the GCC, it's ranked the 3rd. That's after Bahrain and Qatar. The cumulative risk of having this type of cancer is about 1 in 56 among males. That's before the age 74 or 75, whereas the female is one case of incidence in 167. The Kuwaitis and non-Kuwaitis share the sphere, about 50% of incidence, and most of them are males, like more than 2/3 are males. Most of them above 60, so we know that lung cancer is the disease of elderly, both in Kuwaitis and non-Kuwaitis. If we divided Kuwait into districts and governorates, the Kuwaitis cases, most of them, about 1/3, comes from the capital, about 30%. And the non-Kuwaitis comes from Hawali and comes from Farwania, which makes sense because of the distribution. Most of the cancers are actually non-small lung cancer for both Kuwaitis and non-Kuwaitis. And the mortality rate is probably the highest among all cancers. It's about 8 to 10 cases in 100,000 population. So what are the risk factors of lung cancer? There are many of them. But the primary factor are, number 1, smoking, Number 2, smoking. I think you're going to get the idea. Number 3, whatever the smoking is, it's still smoking. And number 4, discount how going to be if you smoke. Right? The other risk factors are maybe occupational and environmental. We have genetic factors, disease, benign diseases of the lung, like inflammatory diseases and benign disorders, dietary factors, and age with race. The age, as we saw earlier, it's like a disease of elderly, and the race, according to one of the American studies in Jama, it's basically black African, the African American people, they get it more than the Caucasian. So smoking is the primary risk factor of lung cancer, and 90% of lung cancer are caused by smoking. If you smoke 1 pack per day for 40 years, you will increase the risk up to 20 to 30 fold more than the non-smoker. However, the trends in Kuwait, smoking trends in Kuwait, probably is not really right. So the prevalence is about between 23 to 25%, and the proportion of smoking in males more than females, about 9-fold more. In Kuwait, the smoking average age is about 18 years of age, so they start smoking at this age. And average years of smoking is more or less 14 years or 15 years, and the average amount of tobacco is about 1 pack per day. This is the trend in Kuwait. So how did we get the link between smoking and lung cancer? It started when Sir Edward in 1912, he first reported and suggested actually that the possibility of cigarette inhalation and lung cancer. At that time, the lung cancer incidence is about like 1% only. Until 1950, the first official report, epidemiological report, was published by Dole. He stated, or at least he proved that there is correlation between smoking and lung cancer death. So what happened? These tobacco companies, the executives, went to the Congress and swore that it has nothing to do with smoking. 1964, just 2 years after that, the Surgeon General of the United States concluded that cigarette smoking is the major cause of lung cancer. All right, so they put the dots with Arabic and that's it. That was the indirect effect or indirect correlation between smoking and lung cancer. The direct correlation in 1996 was the first published study. They studied the lung cancer specimens and the autopsies. They found that the benzometabolites, the pyrene, this is from one of the tobacco's component, it damages actually the P53, which is the tumor suppressor gene, at 3 loci, and that's why it affects, it starts and it initiates the lung cancer process. It was found actually abnormal. The P53 was found abnormal in 60% of lung cancer patients. So the risk of smoking and lung cancer is proportional to the total lifetime consumption of cigarettes. The relative risk is about 20 to 30 folds. The relative risk of having lung cancer is actually increasing with the number of cigarettes per day and number of years. The other risk factors, or the other factors that associated with smoking, of course, is the age of onset, the degree of inhalation, the tar and nicotine content, and whether the cigarettes are filtered or not filtered. I'm sure most of you know this problem. But what about second-hand smoking? Nowadays they call them environmental smokers. So this problem actually starts, the second-hand smoking starts from childhood and adulthood. So if you have a child that has a household, parents or brother or whatsoever, family member, that smokes more than 25 cigarettes per year, the risk increases of their risk, the non-smoker, the children, and the adults there, increases by 17%, or increasing to 17%, from nothing to 17%. In other studies, it showed that it increased between 25 to 30%. Why? At the beginning, nobody knows. But then they started to study the non-smokers who had lung cancer, and they took a urine sample. They found something called cotinine in the urine sample. The cotinine is actually a metabolite of nicotine. All right? They found it significantly available in their urine. And the other proof that the other theory that lung cancer occurs in non-smokers, second-hand smokers, when they also found that those people, those patients, they have a defected an enzyme that is responsible for detoxifying carcinogens from tobacco. The other element that's associated with lung cancer or risk factor is radon. Radon is a decay products of uranium and radium, and it is found in soils, rocks, groundwater. It accumulates in water, and the radon gas actually damages respiratory epithelium and causes chronic inflammation. On and on, because they release the alpha particles, which are the free radicals. There is a meta-analysis of a 13 European study, a case-control study, reported a linear relationship between amount of radon accumulated in the houses and homes and the cancer. It's about 2%. So 2% are caused by radon. The death rate is between 7,000 and 36,000. But do we have radon in Kuwait? Do we have radiation in Kuwait? That's a question. You don't think so, right? Me too, I didn't think so. But the problem that this area has been exposed to wars since 1990. And the American armies, plus the WikiLeaks documents, they published that they used tactical bombs or limited nuclear bombs. Where did they bury it? Where did they bury the waste? I can't say that. To be politically correct, actually. I don't want to say that. But actually, there are some documents mention that it is buried in Kuwait. But during my literature, actually, one of my friends helped me with that. I found this article was published in 2005, and they say that they found a BB in the soil. BB 2000. This is 210 BB, which is a combination between radon daughters and the lead found in the soil and the dust, and they found it available here in high concentration. And it occurs actually mostly the amount is increasing during the summertime, where the dust increases and it moves everything. So we have radiation here. All right, genetic factors is poorly understood. There's a lot of studies going on. And some of the studies prove that it's genetically, you are genetically either ready to have lung cancer or you are not. But it's still like, it's going on. But what is established in the proof that if you have a family member that has lung cancer diagnosed early, you have a chance of getting lung cancer as a first-degree member. First-degree relative. It's about like 1.8, that's around 25%. Or in early ages. Patient who has COPD, fibrosis, alpha-1 antitrypsin deficiency, they are actually at more risk of developing lung cancer than the rest of the population. Why? Because of chronic inflammation in their respiratory epithelium. And they found, incidentally, actually they found that those patients who uses COPD, who uses inhaled steroids, the risk of lung cancer is becoming less and less. But they have lower incidence. Dietary factors, we all know that there are a lot of foods, they have antioxidants and fruits, greens, and yellow vegetables, citrus fruits, parsley, onions. They are full of good nutrients. And we have this prospective cohort over 16 years on almost 2,600 patients. They found that those are at risk of developing lung cancer, and they found that patient who has a high intake of flavonoids, they actually have lower incidence of lung cancer. Now, I was asking myself all the time, is there a difference between male and females that develop lung cancer? Are we more prone to get lung cancer, or females are more prone to lung cancer? We know statistically that men are taking the lead in lung cancer incidence. But in fact, what I found that females are getting lung cancer, or they will get lung cancer, and even low intensity of smoking. For example, if male smokes 20 packs per year, and the female smokes 10 packs a year, still they get lung cancer at low intensity. So the risk is there. But the question is why? We know the risk factor is smoking, definitely. But one of the studies actually published done by Women Health Initiative trial, they found that it's a control study, and they found that patients on hormonal therapy and other group, the control group is on placebo. They found that patient who's on hormonal therapy and smoking, they have higher incidence, and they have worse prognosis worse survival from lung cancer. So they concluded that hormones either accelerates the transition or promotes the growth of lung cancer. Now we'll shift gears to other topic, or same path. Screening of lung cancer. And I asked myself, probably you should ask yourself, is screening important in non-small cell lung carcinoma? My answer is going to be absolutely. Lung cancer, when they present usually late. They have high mortality rate, they have high low survival rate. So why screening again is important? Because of those points. We also know that we have identified risk factors. We already know that smoking can cause lung cancer. And we also know that radon and bad dieting and other stuff that could cause lung cancer. I added the last point here, which is that besides those points, it's important because we can avoid both psychosocial and economic burden of lung cancer. It has been shown that people who develop lung cancer, 25%, they develop some sort of psychosocial or depression problems. And in order to avoid this, they concluded, or they recommended, that you have to do screening and to intervene early to improve the quality of life of those patients. And there are two studies about economic burdens, one from Canada and one from the States. The one from Canada, they thought that patients with lung cancer from diagnosis till treatment, without the treatment, cost $7,000. 2,000 of them then cost $20 million. That's a little bit expensive in Canada, though. While the States, they run a study, a case control study, and they studied those patients who are diagnosed with lung cancer and patients who are going to the emergency for regular care, like for flu and stuff like that. And they found a huge difference between a cancer patient and the regular patients. And the total amount is about 46,000 versus 2,000. And you have to add like $10,000 more if they fail the first line of treatment. So the concept of screening is to identify and to treat the precancerous or cancerous states at the asymptomatic status. This will prevent the occurrence and improve the survival. So what is the ideal tool of screening? Number one, it should be very sensitive, it should be very specific, it should be safe, acceptable for both the patients and the doctors. It has low cost, and it has either low morbidity or mortality. But it's not completely safe. Nothing is like perfect. The problem with screening is that you're going to detect a benign problems, benign nodules, and this will put the patient into like a vicious circle. He's going to be following you for a longer time, and he's going to be needing more investigation, like more CT scan, more intervention, like fine needle aspiration, and so on. This all will increase the anxiety for both myself as a doctor and increase the anxiety of the patient. The screening started like in the 1960s. The first screening study started by using chest X-ray and sputum. The largest one was something called the PLCO, which is the prostate, lung, colorectal, and ovarian cancer screening program. They recruited 155,000. They choose the patient, and they asked the patient to take a chest X-ray on an annual basis for 3 years. Each year, one chest X-ray for smokers and non-smokers. And they found that both smokers and non-smokers, they have the same abnormality, about 9%. And they concluded the study that there is no difference between, on X-rays, between smokers and non-smokers, in terms of the incidence and in terms of mortality. So, their recommendation that do not use chest X-ray as a screening method. And then CT scan came into the play. Especially when we had the new machines of CT scan. They're high definition, and they are basically a low dose of radiation. For the screening with CT scan, we have one large, that's going to be the benchmark study, and this is going to be the study that's going to change the face of lung cancer management. So it's called the NLST, the National Lung Screening Trial. It's a huge trial. It's a randomized control, very powerful, and they convert CT scan to chest X-ray for 3 years. They recruited 53,000 patients. Those patients are high-risk patients. They are basically either the age group between 55 to 74. And they smoke 30 packs per year, either currently or they stopped at least for the last 15 years. This study was stopped in November 2010. Why? Because they noticed that it has a significant benefit. The screening with CT scan is very beneficial. They found that the CT group had 645 cancers per 100,000 versus chest X-ray group 572. It seems that not much difference, but statistically it's going to be significant. The CT scan discovered stage 1 lung cancer about 70% of their studies, whereas chest X-ray only 56%. And the cancer death was in CT group 274 versus 310. So their conclusion that CT screening does reduce mortality by 20%. Because of that study, the 2012 NCCN guidelines, they correlated and implicated the screening into their guidelines. So I think for the next few years you're going to see a lot of screening programs going on, probably perhaps in Kuwait too. Other technologies are really under investigation. We use a lot of those techniques. They're going to be studied actually. PET CT scan, fluoroscopy, fluorescence bronchoscopy, and so on. But nothing really came up. The other question came to my mind is, can we prevent lung cancer? Can we prevent it or not? What's that? Remove the lung? That's not prevention. All right. The answer is of course, but the question is how again? Simply, just be healthy, guys and girls. Just be healthy. The incidence we know now, the incidence of lung cancer and mortality can be reduced by early detection, as we discussed earlier, and smoking avoidance and cessation, chemo prevention, I'm going to talk a little bit about it, and treatment of disease, of course. But smoking cessation is the most effective way to reduce the risk of lung cancer. For example, well, this is a study done in the UK when they found that in 1990 found that smoking cessation reduced half of lung cancer incidence at the age or before the age of 70. And the earlier you stop, the earlier you reduce the lung cancer. For example, if you stop at the age of 60, then the lung cancer risk will be 10% of the original risk. But if you stop at the age of 30, lung cancer will be 2% of the risk. So the question again, does it decrease the risk? The answer is yes, from 20 to 90%. And it could be evident for the first 5 years of smoke cessation. But if you stop 10 years before 10 years smoking, then the risk will be cut down to 50% of the original risk. And one of the studies actually, if you stop 15 years, you're gonna reduce the risk down to or up to 80 to 90%. But you know, some patient comes to you and says, like, I'm so addicted to smoking, I can't really stop. What should I do? If they cannot stop, at least ask them to decrease or reduce or cut down the smoking by 50%. Because we have a study, although it's observational, but still we have a study that if you stop smoking by 50% or more, then you're actually reducing the risk by 27% or 30%. So at least, if you cannot ask them to stop it, at least ask them to cut down 50% of smoking. But again, best thing is to prevent initiation from the beginning, especially during childhood and adulthood. What we need here, we need campaigns, we need awareness campaigns, and we need also rules and laws to be reinforced to stop that kind of behavior. What else we have? We have diet. My piece of advice, get green and get fruity. This is my piece of advice. We all know that flavonoids decrease incidence or have lower incidence. And one of the studies I came across actually mentioned that fruits may decrease incidence by 25%. This is a huge number. Probably they're not powerful studies, but still we have some sort of a hope to grab on. What else we can do? Exercise. I know you medical students probably don't exercise. Most of you don't exercise. But exercise is very important, and analysis of 9 studies, they found that patients or persons who are smokers with high physical activity, the incidence rate is reduced by 30%. Chemo prevention is not really understood, it's not really established yet. We need a lot of studies, but chemo prevention came from other studies like colon cancer or prostate or breast cancers. The idea or the principle is that we use agent to prevent damaging of the DNA. But in lung cancer, we don't have any evidence and we don't have anything established. The only one study I came across is that it has been stopped and banned actually, using high concentration of vitamin A and beta carotene. They found that it might increase the incidence and death of patients with lung cancer. There are lots of agents that need investigation, but we need more studies and nothing is recommended. For pathology, we have two main categories of lung cancer. We have either small cell or non-small cell. The most common is adenocarcinoma of the non-small cell. Patients with lung cancer either present the symptoms presenting due to local effect or regional effect or distant and paraneoplastic syndrome. But the local effects mostly are coughing. 75% are they cough. And if you have patient, smoker and older age with hemoptysis, then you have to really take it seriously. Patient with hemoptysis and smoker, that means that they are having lung cancer unless proven otherwise. This is basically local effect, but we have regional effect like pancreas tumor. Patient will present with pain and shoulder pain and Horner syndrome. We have something called paraneoplastic syndrome. The paraneoplastic syndrome actually the tumor secretes hormones and secretes cytokines that act distantly. And for example, the non-small cell like carcinoma, they have hypercalcemia, they present with hypercalcemia. And they present with something called HPO, which is hypertrophic osteoarthropathy. But the most common paraneoplastic syndrome in small cell lung carcinoma is SRAD, syndrome of inappropriate antidiuretic hormone. They present with hyponatremia. For diagnosis and staging of lung cancer, we are following the guidelines of ACCP. That was published in 2007 in the Chest Journal, and they insisted that every patient suspicious of lung cancer, you have to get, or you have to have a detailed history and physical examination. So, history and physical examination is still very important at your level and at our level. And then we start with non-invasive techniques like chest X-ray and CT scan. CT scan of the chest and the upper abdomen. Sometimes if you're suspecting any lesion in the head, for example, patient complaining new headaches or neurological symptoms, you have to do a CT head. The other things of non-invasive techniques is we use PET and CT scan. You came across PET and CT scan, right? PET CT. So you know that we use something called 18 fluorodeoxyglucose. It's based on the fact that tumors they have high metabolic rate, so they consume more glucose than the regular tissue or normal tissue. So PET and CT scan detect based on the uptake of the trace, detect the lesion and also detect if there is any metastasis anywhere else, except of course in the brain, because the brain is very active. If you don't have a PET scan or it's very expensive, then you can do bone scan instead of PET scan to rule out bone metastasis. Now we have a lesion in the lung, but we don't know what that lesion means unless we get something called tissue diagnosis. How do we get it? By either tissue diagnosis from the tumor or tissue diagnosis from the lymph node. So from the tumor, most of the time we use the FNAC, fine needle aspiration cytology or biopsy, under radiology guidance. Okay, so they stick a needle inside the lesion and they aspirate and send for pathology or histology. Or we can take directly from the bronchoscopy. You evaluate the bronchus, if you see the lesion, you can biopsy it. But for lymph nodes, we have different techniques. Either we use the conventional technique, which is cervical bystanoscopy with a rigid scope and the neck, like do a small incision. Or we use nowadays, for the last probably 10 years, we use something called EBUS, endoscopic bronchial ultrasound. And we use EUS, which is endoscopic ultrasound, to evaluate the lymph nodes, evaluate the tumor, and also to reach the lymph nodes that we cannot reach by the conventional methods. At the extremes, we go for surgery to biopsy, either by VATS, which is video-assisted thoracoscopy surgery, or by thoracotomy. Once we get the diagnosis, then we have to put them in the TNM staging system. T stands for size, N for lymph nodes, and M for metastasis. And then we have to group them into groups and stages. Why? Because it's going to affect our treatment plan and it's going to affect our prognosis for the patients. But for treatment, it depends on tumor histology. Whether it's a small cell carcinoma or non-small cell carcinoma. If it's small cell carcinoma, the treatment is not surgical most of the time. 90% is going to be chemotherapy and radiotherapy. It depends also on the stage or the extent of the disease, and also depends on the patient's factor, whether the patients are operable or not operable. Can the patient tolerate the anesthesia or not? In general, treatment is either going to be curative or palliative, and we have modalities of treatment. Surgery, for example, the surgeries ranging from very extreme, that pneumonectomies, removing the whole lung, or lobectomies, going one lobe, or limited resection, like a wedge resection or segmentectomy. And then we have other modalities like chemotherapy, radiotherapy, and palliative RFA, which is radiofrequency ablation using ultrasonic techniques. The treatment guidelines of lung cancer, if you have like early stage from stage 1 to stage 2, the treatment is surgery. Surgery is the treatment for the early stages. But if you have stage 4, then treatment is palliative. Stage 3 is in between. Like most of the time is chemo and radiotherapy, but in some situations we use surgery as a trimodality treatment. Usually the outcome of lung cancer depends on the stage. For example, stage 1, the outcome is more than 75%, 5 years survival. But if you have stage 4, you have less than 1% 5 years survival. In conclusion, I know it's very long and it's very heavy, but in conclusion, lung cancer is the most common cancer. It has the highest mortality in males and females. Lung cancer in Kuwait is the 4th cancer, and females the 9th cancer. We all know now that smoking is the primary risk factors, and we all know by evidence, very strong evidence that screening with CT scan will detect early stages and decrease mortality. The best prevention is smoking cessation, and the treatment, of course, depends on stage of the disease. So the take-home message is please stop smoking, smoker. Be healthy, adopt a good lifestyle. We need, I missed the need here, but we need the national campaigns. We need national campaigns of awareness, especially for kids and for young adults. And of course, we need to reinforce and activate the laws we have here. The bottom line is yes, we can hold the horses and we can kill the beast. Thank you very much.
السلام عليكم. دكتور بس بدي أسألك electrical cigarettes, are they better than the normal cigarettes?
This is a good question. I've been seeing a lot of ads nowadays on electrical cigarettes. The only thing I know that it releases with nicotine. بس مثل ما انتم شفتوا واحدة من الدراسات for non-smokers, the second-hand smoker, they found metabolites of nicotine in the urine of non-smoker lung cancer people. So to me, honestly, I don't know about that question. But thank you very much.